Hello, my name is Kelsey. Today, I will be presenting my analysis of escitalopram's effectiveness in achieving remission among females diagnosed with major depressive disorder. Escitalopram, commonly known by its brand name Lexapro, is a selective serotonin reuptake inhibitor or SSRI. It is among the most widely prescribed antidepressants globally. Clinical research has shown that escitalopram tends to outperform other antidepressants during the acute phase of treatment for major depressive disorder, offering better efficacy, tolerability, and acceptability. The main goal of my project was to investigate the effectiveness of escitalopram in achieving remission among females diagnosed with major depressive disorder. In addition, I aim to assess the predictive accuracy of the model developed for remission outcomes and to identify any potential biases present in the dataset or modeling process. For this study, remission was operationally defined as the patient taking escitalopram continuously for 10 weeks or 70 days without switching to or starting another antidepressant. This definition helps us approximate successful treatment outcomes using real-world clinical data. The methodology involved several key steps. First, I created the database by extracting relevant antidepressant treatment records. Next, the dataset was prepared by merging clinical and demographic information and engineering features such as age and remission history. Data was cleaned to ensure quality, likelihood ratios were calculated, and a predictive model was developed to estimate the likelihood of remission based on patient history. Initial database creation focused on collecting treatment and diagnostic information for patients prescribed escitalopram. This involved organizing antidepressant information, aligning medication dates, and establishing trial identifiers to track treatment courses accurately. Dataset preparation involved merging medication history with demographic profiles, calculating patient age at the start of treatment, and identifying remission status. Indicators for key demographics like race, ethnicity, and sex at birth were also created, along with age range categories to allow for stratified analysis. Data cleaning focused on correcting inconsistencies in date fields, removing duplicate entries, and ensuring that all clinical timelines were properly structured. A series of checkpoints were created to ensure that intermediate datasets could be recovered easily if needed. After cleaning, logistic regression modeling was used to predict the likelihood of remission. Features with low variability were removed to avoid biasing the model. One hot encoding was applied to categorical variables, and the dataset was split into training and testing groups. Model performance was evaluated using classification metrics such as accuracy, precision, recall, F1 score, and area under the ROC curve. The model achieved an accuracy of 63% with a precision of 65% and a recall of 74%. The F1 score was 69%, reflecting a good balance between precision and recall. The area under the ROC curve was calculated at 68.3%, slightly below the published benchmark of 70.4%. This indicates moderate discriminative ability, meaning the model can reasonably distinguish between remission and non-remission cases, but still has room for improvement. Displayed are my top 20 features in order of importance, and next are my descriptive statistics. When reviewing the model's performance, several important insights emerged. First, the calculated area under the ROC curve, or ROC, was 68.3%, which is slightly lower than the published ROC benchmark of 70.4%. This suggests that while the model performs moderately well, there is some room for improvement in discriminating between remission and non-remission cases. Second, there was noticeable demographic imbalance in the dataset. Only 14% of trials involved African American patients, and about 12% involved Hispanic patients. This underrepresentation could introduce bias and limit the generalizability of the model's predictions. Finally, the model exhibited a high number of both false positives and false negatives, indicating challenges in accurately predicting remission outcomes. This reinforces the complexity of modeling antidepressant responses and highlights the need for further refinement. There are important limitations to note. Despite including over 10,000 unique medical conditions, critical psychosocial factors like social support, medication adherence, or therapy participation were not captured. This lack of depth may have limited the model's predictive power. Nonetheless, the findings demonstrate the potential for using historical health data to inform clinical decision-making. Future predictive models should work to include more diverse populations and a broader range of factors to improve both fairness and accuracy. Thank you for your time and attention. I would be happy to answer any questions.